Thank you very much. Welcome to our panel session. This morning, we will be taking you through our topic, which we're asking ourselves, was healthcare infrastructure unprepared? I would like to go straight into the conversation that we would like to have this morning. At the onset of the COVID-19 pandemic, the Ministry of Health carried out a survey on the healthcare infrastructure across the country with an aim to improve existing facilities at both national and county levels as the number of cases were rising. It is evident that remarkable improvement has been made, but more needs to be done. What challenges affect the rolling out of healthcare infrastructure at government level, and what can be done to continuously improve healthcare infrastructure post-COVID-19 in order to attain universal healthcare for the citizens of Kenya? Welcome, Dr. Mercy, and we'd like to hear your insights on this particular query.
Thank you so much, Architect Nyole, and thank you to my fellow panelists for being here today. Let me begin by saying that health infrastructure is an important building block of the health system. In fact, before COVID-19, health fraternities and the public health space had recognized the vital role that health infrastructure plays in enabling access to health services. During COVID-19, it is true, as highlighted by Architect Nyole, we were able to carry out an assessment, and this assessment was undertaken in various hospitals across the 47 counties. And really what we got as a result of our assessment is a mixed picture. We ticked some boxes, we did well in some areas, we could do better in other areas. And perhaps to begin with, perhaps the brick and mortar of a health facility. Our assessment showed us that, by and by, when it comes to having, that capital infrastructure of a health facility, yes, Kenya was ready. Kenya did have an ample number of health facilities. However, when we dig deeper and when we try to get a granular picture of how did these health facilities respond to the COVID-19 pandemic, we realize that there are areas of improvement, in different spaces. For example, we all know that COVID-19 brought about the need for isolation and quarantine facilities. And of course, despite having, the brick and mortar infrastructure available, it became necessary through the response to actually readapt what we had on ground. And these adaptations, touched on different areas. For example, issues to do with ventilation of the different rooms, issues to do with ablution blocks that are available in the different health infrastructural facilities, issues to do with even the ease and functioning of the healthcare workers. How does a healthcare worker perform the role that they're supposed to do in a manner that is easy, that is safe for them, that is also safe for the patient? And so indeed, our assessment, shows us that there are a few areas of, improvement that require to be done, and particularly not just in the health facility, because our assessment also looked at our laboratory facilities, a key component of the COVID-19 response. And we were able to really ask ourselves, questions. Are our labs ready when it comes to, a threat such as COVID-19, which, can be termed as a public health emergency? Do we have the right flow mechanisms and flow pathways in our laboratories to be able to deal with, agents that are infectious and that are dangerous when it comes to public health emergencies? And perhaps, again, this conversation was extended outside of the health facility infrastructure to our border crossings, to our airport border crossings, to our ground crossings. Did we have adequate isolation facilities at the airports? Did we have adequate isolation facilities at ground crossings? And really, we've learned numerous lessons that we're willing to share with you during this panel, where we did well and where we can improve.
Thank you very much, Dr. Mercy, for that insight. And indeed, we believe that a lot has been done by the government, and more shall continue to be done in the coming days. And I'd like to quickly move to someone who actually works right at the hospital, Dr. Majid. Tell us, what are the changes you had to make in your day-to-day operations at the hospital at the advent of COVID-19, and how did it affect the business of healthcare coming from more of a private sector operator? Kindly give us your insight on that.
Thank you, Architect Nyole. Very insightful response from Madam Mwangangi. So what she says is the same situation we found ourselves in. The first step was to assess our facilities and our services that we offer. We had to learn as we went along, because remember that our first case in Kenya was reported in March, whereas in the world, the first case was reported in December. So that period was very, very short. When we got our first case, Fortunately for us, there were fairly mild cases that required isolation in the hospital, and we were able to learn without causing too much anxiety or panic. So step one was we had created an isolation space of only 8 beds, thinking that would have been enough. But we quickly realized that that would not be adequate. And then the complexity of COVID. How do you organize patients who come in who are suspected, those who are confirmed positive, and those who are negative? So that combination became very challenging, because before somebody is confirmed positive, you can't mix them with those who are positive. But they are not yet confirmed negative, so you can't put them in the general population. So we quickly had to make a lot of adjustment. Fortunately, I'm saying fortunately, or at that time it looked like it was unfortunate, a lot of the patients had run away from the hospitals. And with this, we had a lot of space within the hospital that we could quickly adjust. So we started creating isolation spaces. We created specific isolation spaces within the intensive care unit, because we anticipated some of our patients will end up there. We had to create negative pressure rooms. We created a field hospital in case we got overwhelmed, or 40-bed field hospital. Very challenging, and lots of lessons to learn from that as well. As the numbers increased, we barely got to use it, which was a good thing. But remember that this happened around March. It was getting very cold. By July, it was extremely cold, yet the field hospital did not have any heating system. So we had to think about heating. Now we realize that we have oxygen-enriched atmosphere. Because of COVID patients requiring oxygen, we had to bring in oxygen into the field hospital. Now, balancing all these different areas was quite a challenge, but with the help of our architects and our engineering colleagues, we were able to design reasonable facilities. The other one, as Madam Mwangangi had said, even patient to ablution ratios was an issue. We had to quickly sort that bit out.
Thank you very much, Dr. Majid. And I'd like now to move slightly beyond just Nairobi and even beyond Kenya. And I'd move to Dr. Amit. The Kenya Healthcare Federation was at the forefront of creating awareness and emphasizing on improvement of infrastructure in preparedness of the COVID-19 pandemic. What would you say were the successes and areas of improvement that were experienced during this season within Kenya, in East Africa and beyond, knowing that you have a lot of experience, not only within our country, but also across Africa? Kindly share your insights with us.
Thank you, Florence. So let me just begin. It was the first time actually Kenya Healthcare Federation and Florence, your organization, Architecture of Association of Kenya, started working together. In 14 years, we had never worked together. And we now realized there was one major area in the healthcare system that we probably have not been bringing up. And thanks to the pandemic, now we have a good working relation between the architects and health. It was just like 4 weeks into the surge that I called Dr. Mwangangi once and talked to her about this. And she quickly came on a Saturday with many of the architects from your association. And I remember Caleb also being there, and how it was very important. What it uncovered is that there was an important feature of the design of hospitals that we hadn't looked at very carefully. Every hospital, whether it was a rural hospital, I remember having called by Diani Beach Hospital in Mombasa. We also had a call with Nairobi Hospital. Everyone agreed that the new hospital design of the future in Africa is going to change. It will cater for dealing with infection prevention control like they've never done before. They will make provisions of having triage like they've never had before. They will model on flexibility, like Majid was mentioning, like they've never done before. It has taught us a lot. And I can tell you, 10 years later, the infrastructure for healthcare on this continent is going to be really different. This is something that I think we've learned. It's a takeaway. Were we prepared when it hit? I think not. There is also a cost element that I must bring out here. It's not easy, especially in private sector and public sector, to start managing appropriate infrastructure. It is quite costly. And if you ask Architect Caleb, he will tell you quite a few $1 million were used to create an annex that will effectively try and cater for the COVID patient, not to mention that payments for these patients were also a concern with the reduction of utilization of healthcare services with elective cases coming down. So the income was dropping for hospitals, and yet they needed to make investments to raise the infrastructure up. This created a dilemma because many hospital owners across our country were thinking how best to economically manage. What did we do? We thought of tents. And you saw many private sector hospitals created a triage in the parking area using a tented structure to reduce costs, to manage who's positive, who's not positive, and how to manage this process.
Thank you very much, Dr. Amit. I think moving forward to the expert who is an architect, but also an expert in hospital design, Architect Caleb Mutali. It was evident that our healthcare infrastructure was inadequate for isolation and treatment of COVID-19 patients. What has been your experience in responding to this inadequacy as an expert in hospital architecture? And what are the short-term, long-term interventions required to improve these facilities in preparation for COVID-19? I'm looking at the backdrop that there was an emergency, but now there could be an opportunity to look at long-term solutions going forward. Could you kindly give us your insights on the same?
Thank you so much, Architect Florence. And thank you also my co-panelists for the very insightful thoughts that you have shared regarding the pandemic that hit us. The most important thing about the pandemic, what we could call a pandemic in other parts of the world, from history, is that different from what has been there historically, this particular pandemic came without warning, did not give ample notice, because normally you would have an epicenter of a pandemic, and then we are saying that there's a time lag between it spreading all over the world. But from what we've shared right now from the rest of the panelists, we hear that it happened or began happening in December, and by March, it was right here in Kenya. So we had a very small window period to try and understand what was upon us. As architects, we traditionally work from what is called a client brief. That is, you begin to understand what the problem is and then try to wrap your mind around it. In this particular case, the client, the active practitioners in the healthcare sector, and even the patients did not know what has come upon them. So there's nobody to describe exactly what it is that we're dealing with. And that became a very huge challenge. However, the small lag that we had, which was a window period between December and March, gave us opportunity to understand that first, we're dealing with a pandemic which is associated with contagions, and these contagions are transmitted by contact or airborne. So that began now helping us to start structuring what we require. The first area of concern is the patient. So we are asking ourselves, when you receive a patient, how do you, the patient is a suspected carrier of COVID-19 or a confirmed case. How do you stop the patient transmitting that particular contagion to any other person who's not infected, to the healthcare workers? So the first intervention is a strategy around the patient. And as Dr. Majid has clearly indicated, that is where the isolation rooms come in. Now, traditionally, when you talk about isolation rooms, there's a lot of science that goes into an isolation room. We have what we call contact isolation. We have something that's called airborne isolation. With COVID-19, we are not just talking about contact isolation, we are talking also of airborne isolation, because we do know that the droplets, and the aerosols around a sick person are known to carry the virus, and they are potentially harmful to the people around it. So the concern is about the air quality. There's also concern about short-term response. The intervention was isolate the patient. We also were talking about interventions where materials and fabric, what we are calling the PPE, the personal protective equipment, was coming in. Those were the short-term interventions. Fortunately for Africa, the time lag helped us in one way. We began to understand the weather that we have here was a big plus. Being in the tropics, we know that the extremely cold temperatures were working against the rapid recovery of any patient who had COVID-19. But because we have temperatures, and the time when it was happening in March was more or less when the sun was overhead the equator, then we could celebrate the fact that the temperature swings, day and night temperatures were not extreme, and therefore a patient could be stabilized quite well when you worry about other parameters and the ambient temperature being comfortable. So that was something that the architect did not have to worry too much about. We were worried about the July season, which then would become a problem. But at the time when COVID hit us, that was something that was working in our favor. Now, going forward, we went ahead and formulated the field hospitals, which is really a rapid response methodology that is used a lot in the army and when you have emergency situations. We need to take note that the information we're using at this point in time is other epidemics that have been there in recent times, such as Ebola or something like influenza. But for COVID-19, we do not have data that is scientific, research-based, that people could say definitively that this is exactly what we need to do. So there's a lot of groping in the dark. And that was really, really the challenge of this epidemic. Fortunately for Africa, the predictions or the trajectories that had been predicted did not come upon us. So it gave us some resilience in terms of how we are responding to this epidemic. But going forward, what do we need to do? The interventions, first of all, at the patient's level, we've talked about that, and we've seen what we are doing at the moment. The second intervention would be at the caregivers level. So we are talking about the family and friends. What do we need to do for them? And one of the things that we need to think about is how do we have our residential homes away now from the healthcare facility, residential homes being repurposed for the purpose of making it a short-term bunker or safe zone for people who may need isolation. I think Dr. Mwangangi, the CAS, can bear witness that when the isolation strategy where home care was being involved came into being, it worked very, very much in favor than having everybody go to the healthcare facilities, which would be overstrained and also which would have a very strong economic and logistic implication to it. But we're saying as architects, right now we are having clients who are thinking about the home office approach as far as design is concerned. We have a number of projects we are doing which are residential, and the clients are telling you, I want to design and bear in mind that in future I may need to be working from home. So what kind of a space is this? How can I have my family probably on the first and second floor, the children running around, but I have an acoustic barrier, I have a privacy, I have a way in which I can deal with all my office work comfortably from home. And this is the new way as far as residential areas are going.
Thank you very much, Architect Caleb. Dr. Mercy, I would like to come back to you now and say that the home-based care as was proposed was a measure to decongest our health facilities because they seem to have been a bit inadequate for isolation and treatment of COVID-19. At that particular time, the cases were really rising. Do you think this improved the number of recoveries from COVID-19? And what would the government do to ensure that if in future this happens again, we do not cripple the healthcare system? Because as we all know, most of the urban dwellers do not even have a conducive environment for living, let alone when isolating COVID-19. Dr. Mercy, welcome to respond to this particular query.
So Kenya put together what was known as a home-based care program. And it is a program that, one, we've received a lot of appreciation and lauding from the world over, because I think probably in Africa, we are one of the few countries who adopted this program. And what we can say is that, one, the program was necessary by the very nature of the disease. In Kenya to date, most of our cases remain asymptomatic, meaning that these are cases who, beyond the risk of transmission that they bear, can actually be managed at home. Two, implementing this program enabled us to actually be able to activate, a key facet of our health system, which is known as the community health strategy. And so the home-based care program involved a monitoring system that was deployed at the community level, where we had volunteers at the community visiting different people who are under the home-based care program, of course, while adhering to the different protocols, and supervising and ensuring that people are going through the program in a manner where they can have good outcomes. Thirdly, the home-based care program, also helped us to be able to perhaps, utilize it for other diseases. It's interesting to note that while we have COVID-19 now as a pandemic, tuberculosis as a disease is actually more infectious than COVID-19, and also has big ramifications when it comes to the health system and the health sector. And long before COVID-19, we used to utilize home-based care for TB patients, and most importantly for MDR. Those are multi-drug resistant TB patients who at a point would not stay in the hospital and would be discharged home once they're stable with a certain number of medications and advice in terms of how they can take care of themselves in the home. So it's something that Kenya had tried before at a very small scale. And so COVID-19 then presented an opportunity for us to be able to expand this and, and to be able to see if this is actually an intervention that would work. We can't say that, yes, it's contributed to, having recoveries who are able to recover with minimal costs. Remember, before home-based care program, most patients required to be admitted for isolation. And you can imagine, having asymptomatic cases, staying in a hospital, accruing a bill for close to 14 days to 21 days, purely on basis of accommodation. So really, those costs were shaved off from the community, shaved off from the health system, and we were able to then have patients recover at home. What is important, and particularly because we're here with architects and collaborating together, would be to then ask the questions that Caleb has highlighted for us. How can future homes be designed in a manner where they're able to be flexible and agile when it comes to the need of their conversion for certain purposes. Different advances across the world show us that healthcare of the future will actually be more at the community level and at the home. We actually have, the Scandinavian countries who are disinvesting from health infrastructure, health hospitals, and sort of trying to reinvest back in communities and in homes, meaning that in the future, your home needs to be a solace. Beyond providing shelter, you need to think about all these elements of your home. And so it becomes important then through such collaborations with the Architectural Association of Kenya to really, spur that question and that conversation. How can your home actually be able to, be a hospice for you?
Thank you very much, Dr. Masi. And speaking of emerging ways of taking care of healthcare, Caleb Mutali, I'd like to just come back to you quite quickly. And in this era of sustainable healthcare architecture, it's important that living spaces used for recovery, we've just talked about it, homes, hospitals, could be schools, should incorporate nature to reduce what you call disease. Kindly expound on this terminology and what would be the benefits of such spaces in mitigating the spread and recovery of COVID-19 and the status of such in Kenya. Talking about our current healthcare system, how can we improve them? Just quite quickly, take us through this particular conversation and your insights on the same. Thank you.
Thank you once again, Architect Nyole. When we talk about disease, the word disease, we do break it up. And Architect Nyole, you are referring to an area of health that is called salutogenesis. It's a long word, salutogenesis, which is really talking about health promotion. So just as we have an environment, and the doctors are here, they could talk about pathogenesis, where you have an environment where we are dealing with the pathogens. There is a school of thought, which has been there. It's a traditional school of thought, but it's becoming very strong in these days, that you can have what is called health promotion. That rather than concentrate on the viruses and the bacteria and the fungi and other disease-causing pathogens, we can also concentrate on promoting health. So we are not looking at the negative, but we can concentrate on people eating healthy, people working out and going to the gym, people having good ventilation, people having good lighting, people walking out in the parks, moving away from congested cities, having lovely neighborhoods. And there is research, a huge body of research that shows that before somebody suffers health failure, the first thing that could happen is the stressors must override the mind. So you can, it's been shown that there's an association between the stress people can undergo to the point where actually there's a what we are calling a psychosomatic effect on their body. So the mind then begins to affect the body, and you find somebody giving up. And this is very strong, especially with the senior adults. We have had people, senior adults, when they give up in life, they can almost detonate. And you find somebody who was well last week, and if they give up, you hear they've actually departed and they're gone, because the mind is the last bastion of defense. So in health promoting architecture, we say that when we have lovely environments that support vitality and vivacity, then the body has a way to reboot, and the immune system is buttressed from a very healthy and strong mind. So salutogenesis is working right from everything that is positive, from good mental health, good environment, clean environments, and positive news coming our way. That therefore said, we are saying that the designs we want to have are going to be designs that incorporate nature. Nature has been shown that there's a very positive energy that comes from good plantations around houses or homesteads or around cities. When people go to the park, there's a way in which they have been known to de-stress and come back, hopeful and ready to tackle whatever challenges they're going through. When people go jogging, when people go swimming, Dr. Mwangangi talked about skydiving, all those kind of challenges, they open up the mind and release all types of stresses, and you find you're like rebooting the whole system, and therefore you move again from that particular area of where you are a potential candidate for illness to actually being resilient. I think this is one of the ways in which the people in the village have been able to fight off COVID-19. Of course, there's no research data right now, but we believe that many of them are really looking out with a very positive outlook as opposed to their compatriots in the cities around the world. So this is an area that needs to be discussed much more, and we believe in architecture, we need to incorporate it in our designs. Thank you.
Thank you very much, Architect Caleb. You have given us a new vocabulary, or at least you have highlighted the new vocabulary that even as architects, we need to create spaces that promote health and focus on the positive part of getting better. And thank you very much. It's something that we all need to note in this particular instance and to take it to the next level. And I believe we do have Dr. Majid here, who happens to work in a hospital that is also a university. And obviously, over and above just being that, it's one of the hospitals that has had the opportunity to take care of patients with COVID-19. Do we expect some research outcome from this experience that could benefit the healthcare industry in terms of infrastructure development, how to take COVID-19 patient care to the next level, given our local context, given the thought of home-based care? We've now talked about salutogenesis. What could be coming out of the hospital with regards to experience of COVID-19? Dr. Majid.
Thank you, Architect Nyole. It's been a very interesting discussion. I've enjoyed my fellow panelists' comments. Very good question. I'd like to highlight that we sometimes too critical on ourselves, and we highlight whether we were ready or not, and the first impression is to say we were not ready. I beg to differ a little bit, because remember, this disease we were learning as we were going along. I believe we were ready at that time, and we continue to be ready and continue to adjust accordingly. I'd like to recognize, for example, our competitor hospital, Nairobi Hospital, put up a beautiful COVID-19 infrastructure with dirty corridors and clean corridors. They were fortunate that at that time, just before COVID happened, they were renovating, and they took advantage to renovate. That in itself was research that was utilized immediately. Knowledge that was acquired was then plowed back into operations. So a lot of stuff that was happening around the world, and knowledge as it was evolving, as it was developing, was being incorporated immediately. And soon after, you'd find that knowledge that we thought was standard would then change. Chloroquine was used initially in treatment of COVID and immediately was dropped when it was found not to be as useful. So even in the infrastructure point of view, a lot of that happened. So this was necessary. So as much as we are blaming ourselves and wrapping up dead bodies in in waterproof cellophane bags. For those who are old enough would remember that's exactly what happened during HIV. We did exactly the same process. As knowledge improved, then we are able to adjust and to learn. So I'm a little more hopeful and I'm a little more positive that it wasn't as bad. We were prepared for that time and we continue to be prepared as we move along. And similarly, as we learn, at my institution, we are keeping all the information so that we can trace the learnings as we go along. That in itself is a process that can be published, how we adjusted, how we were resilient, how we were adaptive in the face of COVID. And we have created a very fat binder that is open to anybody to scrutinize and extract lessons. So similarly, as we went along, as I mentioned, there are some things that we're implementing and then adjusting. We put a field hospital, put in piped oxygen, and then discovered during July that it was too cold. And then we bought flame heaters, and only to realize we can't use them because of oxygen-enriched atmosphere. Would you say we were not prepared because it was getting cold? I think not. I think we were prepared, but we required to learn and to adjust and to adapt. I think that's a bigger lesson, the adaptability, the resilience, the knowledge. I think the biggest lesson with COVID is incorporating knowledge into practice immediately as the knowledge was coming. My biggest frustration in health sciences is we do a lot of good research, but the implementation science is very, very poor. We take too long to implement. COVID has jump-started that bit that knowledge was being implemented as and when it was happening. And because of that, there were mistakes in quotes that happened that required adjustment. So we continue to study COVID, both from an operations point of view, from a medical point of view, and from an infrastructure point of view, and the lessons continue to be incorporated. For example, the entire disruption of supply chain. That's a whole area of learning. Look at the industry that it has spanned. People quickly converted school uniform making factories into PPE making factories. We are proud, as they said, najivunia kuwa Mkenya. We are proud being Kenyans because of how quickly we were able to adjust. All the masks and surgical gowns that we were able to make, all this we were importing from China. Now we are making our own, very, very good quality. The entire masks that we use from the hospitals are actually Kenyan made. So I'm very, very hopeful and I'm very grateful for the lessons learned, and I think we will continue to learn. We are continuing to study COVID from process, from science, from environment, from architect, and we're incorporating these lessons as we continue. Thank you very much.
Thank you very much, Dr. Majid, and for highlighting that Kenyans are definitely a resilient nation. We are resilient people. And it's good to know that there's a binder full of information. I believe as architects, now that we're collaborating, we're working on a collaborative approach, we will come over and look through and see what we can do. Perhaps if we can incorporate some of the things that you have learned in other areas and in other hospitals so that we can improve healthcare as we move forward. And it's so insightful that you remind us that definitely we are adaptive and we are a resilient nation. And that is probably the reason why we've been able to overcome a lot of the challenges that COVID-19 has pushed our way. And even now, as I move to end the questions with Dr. Majid, I'd like all the panelists to prepare their parting shots, which will take just about a minute for each. And Dr. Majid, I would like to end with you. And my question is, like every other Kenyan who's asking, do you think that the curve has flattened? And how can we ensure that it does not peak in the near future? And if indeed it peaks, and we experience a second phase of rise in confirmed cases, what lessons in terms of preparedness of our infrastructure can we borrow to ensure that we are ready? Dr. Amit, over to you.
You know, I too want to appreciate the conversations we've had with all the panelists on this particular subject. And I think what I'm hearing and what's coming out clearly is that prevention is better than cure. And that's coming out very clearly. And it's also going to be more cost effective than cure. I also am hearing that healthcare starts at the homestead and not at the hospital doorstep. So the Big Four agenda in our country also has affordable housing, but it needs to be adjusted so that we can have health at home and we can have productive workforce, that the homestead design that the Architectural Association and experts like yourselves need to look at needs to have a continuum of infrastructure, not just ICU and mechanical and laminar floor ventilation and theater, but also the whole journey, including transport corridors, schooling, which will reduce actually the whole health expenses in our continent. Um, but I think let's also be a bit more practical and mindful. If you look at the slum areas and overcrowded areas and you say we should have gardens and walk around, we might be talking to people who don't relate to what we are discussing here. And so I think clever, organized city planning will be probably non-negotiable for all of us. When we do Nairobi Expressway, when we are building the road, if we are only thinking about the road, what are the health implications during and after, and what can be done in order to boost the livelihoods of people in the city? Has that been thought through? Or is it only electrical, water, movement, and lighting? So now health probably will be embedded in every city planner's docket. Health will be embedded in every land planning. Health will now be a structural involvement, and I wish you, as the architects who are now in the forefront, to ensure that we bring health to the next generation in an affordable, practical manner, that we should be looking at that. So I personally think that these conversations are actually making us as health and planning champions not to leave behind what we've learned. Like Majid says, there's a lot that we've learned. There will be a whole deck of how the healthcare personnel will have to deal with issues, but there'll be another deck of what the non-healthcare personnel will have to deal with. I'll also mention one thing that I don't think we should not flag here. It's the protection of health workers. The doctors, the nurses, the frontline workers. I really, really think that whatever we plan and whatever we approve and accredit, we should be mindful of the very few health workers that exist in Africa. And our design must be built and our focus of our infrastructure must be built to make sure that the nurses remain safe from the theater door corridor, from the corridors of all the ward treatments, and also entry and exit, the donning and doffing, make adequate infrastructure allowances to ensure they have safety when they come into the place of work and they actually go out of the place of work, especially for the healthcare workers that we have seen. And finally, on a parting shot and a good note, I must say that the private sector in Kenya, we should all be very proud of. We are, of course, proud of Ministry of Health, Mercy, you and your team and ministry you've done, but it's through the admirable partnership of public-private that I think we have managed to flatten some of the results that we've seen. I think we are an envy of many countries, not only in Africa, but of the world. I personally have spoken about the public-private engagement that has saved millions of people from illness and sickness of what we have done. We quickly repositioned our factories, like the one we mentioned about producing aprons or PPEs, masks. We are now already exporting some of those. So the private sector came in the forefront in Kenya to work with the government, and that's made us truly a proud nation that will continue strengthening us as we go forward. Thank you.
Thank you very much, Dr. Amit, and for your insights and for actually wrapping it up for us.